Good afternoon, everyone. I would like to call to order the State Employee Benefits Committee meeting for Tuesday, November 25th. I'd like Danielle Cross with the Statewide Benefits Office to do roll call of all SCBC members to document attendance.
Director Maxwell,
Present.
Secretary Gordon,
Present.
Lieutenant Governor Gay,
Present.
Treasurer Davis, Commissioner Navarro,
Present.
Secretary Young, Deputy State Court Administrator Evelyn Nesselrod,
Present.
Jeff Tasner,
Present.
Paul Bombach,
Present.
Karen Peterson,
Present.
Bill Oberly.
Here.
You have a good treasurer. Treasurer Davis.
Aye. Present.
Thank you. Moving on to agenda item number 2, it will be the approval of the October 28th, 2025 SCBC meeting minutes. Are there any, I'll entertain a motion to approve the minutes.
I move, Yvonne Gordon, I move that we approve the minutes of the October 28th, 2025 SCBC meeting.
Right, so we have a motion. Do I have a second?
Second.
So I got a second. Any discussion on the motion? Seeing none, are we gonna do it? We don't need, can we do a voice vote if that's okay? All those in favor say aye.
Aye. Aye.
Opposed? Would anybody like to abstain?
This is Evelyn Nesselrode. I would like to abstain, please. As I was not present.
Thank you. Meeting minutes have been approved. So I will turn it over to Director Hardos for the Statewide Benefits Office Director's Report.
Thank you, Director Maxwell. So I'll start with some RFP updates. The first being the Health Data Warehouse procurement. As noted during the October SCBC meeting, the Statewide Benefits Office received 5 vendor proposals for the Health Data Warehouse procurement. Those vendors are Artemis Health, Certalytics, Meritive, OnPoint Health Data, and UPMC Work Partners. After review of the proposals against the minimum requirements established by the SCBC, it was determined that all 5 vendors meet the minimum requirements, meaning they will be moving forward for evaluation by the Proposal Review Committee. The first Proposal Review Committee meeting and vendor interviews are scheduled for December 8th and December 10th. Our next procurement for vision benefits, the PRC continues to evaluate proposals from the final 3 finalists. Those are iMed, MetLife, and VSP Vision Care. Interviews were completed in early November, and the final PRC meeting is scheduled for December 11th. The PRC recommendation is anticipated to be shared with the committee for review at the January 26th SCBC meeting. I do also have a few general committee updates. The first being the 2026 meeting schedule. All committee members should have received invites for the 2026 SCBC meetings. Beginning in January, SCBC meetings will now be moved to Mondays and will take place from 10 a.m. to 12 p.m. to work around the upcoming legislative session. For most months, these meetings will take place on the last Monday of the month, though there are a few exceptions due to state holidays and meeting conflicts. But the full 2026 schedule is posted on the SCBC website, as well as on the public meetings calendar. Meetings will continue to be held in a hybrid format. The second item, SCBC agendas. So as noted at the October committee meeting, SCBC agendas no longer indicate voting items via an asterisk. However, agenda items anticipated for a vote will be described as approval of before the agenda item. Please note that SCBC does retain full authority to vote on any item listed on an agenda, regardless of whether approval is indicated in the title. And the last update I have is related to accessibility. To comply with new federal and state accessibility requirements, you may have noticed that real-time closed captioning is being shown on the screen, just to ensure that SEBC meetings, as well as all SEBC materials, are as accessible as possible. So for in-person meeting attendees, of course, the transcript cannot pick up your name unless you state it for the record. So just want to remind the committee and ask that before you make a comment or a motion, if you could just state your names, that way it can be documented for accessibility purposes as well as for the record. That would be greatly appreciated. Any questions on the updates for today? All right, well, thank you, Director Maxwell. Back to you.
All right, agenda item number 4, medical third-party administrator services request for proposal, scope of work. I believe we have Hope here to run us through a little presentation or PowerPoint.
Thank you, Director Maxwell. Hope Mannion with WTW, and just going to talk through how the scope of services for the medical TPA RFP is shaping up. To just get started thinking about how we want to approach this project and the objectives for the project of the procurement. So a little background, the state of Delaware provides medical benefits to just shy of about 125,000 members, mostly including state employees and pensioners, as well as spouses and dependent children, enrolled in some medical plans that are currently administered by Aetna and Highmark. There are a couple, we have eligible employees and non-state participating groups, including municipalities and fire companies that are also eligible for state medical benefits. So these groups are all served by the GHIP in this regard. There are currently 4 medical plans available to active eligible members and pre-65 retirees. We have a comprehensive PPO and the First State Basic Plan, which are administered by Highmark, and then the HMO and the CDH, or Consumer Directed Healthcare Gold plan, administered by Aetna. And then Highmark also administers the Special MedicFill Medicare Supplement Program. So for the active programs, the first 4 I mentioned, the contracts expire June 30th, 2027. For the Medicare supplement plan, a little bit later than that, December 31st, 2027. And just a little more context setting, the GHIPs and state benefits are self-insured. Okay, so GHIP is paying claims, retaining the risk for those claims, which is different from a fully insured arrangement where you may be paying a premium to an insurance company and they pay the claims, whether they're low or high, you know what you're paying. So we're really kind of setting up an insurance company, very common in employer-sponsored benefit programs for groups over about 1,000 people. This is the most efficient way to finance your healthcare benefits. So what you're really doing then, or what I should say, and Highmark are really doing, is just helping with the administration in a couple ways. You know, record keeping and adjudicating the claims, paying the claims to providers on behalf of members. The state pays a claims invoice back to the carriers, as well as administrative fees. You're also kind of renting the networks that the carriers have negotiated with providers, right? So you're getting the benefit of all those provider discounts that they've arranged. And then in terms of like budget rates and how we determine what the employees and retirees may pay, W2W, we do actuarial work to develop budget and pricing rates. Mr. Stitzel, you know him pretty well. He's leading that work, and then those ultimately inform, provide one piece of input into how the state decides to set employee contributions for the future year. And what employees and pensioners are paying will vary depending on what plan they've chosen, as well as what tier or how many people they're covering, be it just themselves or families and children. Okay. Okay, so we have a lot of considerations to build in here, and I'm not going to read every single one. I'll just try to stick to some broad themes. But the idea is here is it's kind of been a while since you've re-procured for these partners. The medical and health insurance landscape changes pretty quickly from year to year. So every time we're doing a procurement, we just want to make sure we're updating the contract, the arrangement, and our understanding of the capabilities of the carriers to make sure that they can do everything we need them to do. So and then another flavor of considerations has evolved from other RFP projects. So for example, the audit procurement, there are a lot of questions raised about whether or not, this firm's going to be able to communicate with our medical carriers. So we're going to be asking the medical carrier who wants to bid similar questions to that. Are you willing and able to share data with our data warehouse vendor? Are you willing and able to share data with our CEO vendor, and just making sure that all the vendors are able to perform their services together cohesively for GHIP. One kind of exciting, I think, consideration that will be built in is evaluating the option to add a high deductible health plan that's HSA compliant. So currently today, the GHIP offers an HRA plan. This would be a different plan design with a higher deductible that complies with the code, so that a person who has opted that plan can also elect a health savings account, which is an individual account that they own. They can accumulate savings over time and on a tax advantage basis for paying for medical expenses down the road or in retirement. Many states and other public sector, governmental and educational employers have these plans in place today. For sure that, the corporate employer has adopted them even several years before that. So something new that we'll be talking a lot about as we go forward. Again, having mentioned some findings from the audit RFP, just making sure that the bidders are willing and able to provide data so that it can be audited, and they're agreeing to the transparency requirements along those lines, so that all of the good benefits that were just obtained via the claims audit RFP can be realized when we partner with new medical carriers, as well as keeping an eye on their emerging capabilities around real-time and ongoing audits, which you may remember was a point of interest during that. Something for the future potentially. We want to make sure that your TPA partners will and can carve out care management services. It's going to be an important tool going forward, just in terms of optimizing the health of members. So I want to make sure they're willing to play nice along those lines. In the past, we have, SBO has asked bidders to match the current performance guarantees in place in contract. And this time we're going to ask them to offer some performance guarantees and see if we get something interesting and meaningful, maybe that we haven't seen before. So we're just going to open up for a little bit of creativity on the bidders' part there. Yes.
Bill Overly. Hope, I had a question around how the TPA or the RFP might be structured for the TPA. Has there been any thought about having the TPA deal with administrative matters solely and the state direct contracting for pricing?
I would say not at this stage in how this project has developed. Don't see other states having successfully done that at this point. It's possible. I have seen some reference-based pricing arrangements in other states.
I'm not
I don't think
going
it's going to
there
work here.
this
So,
time.
yeah.
My concern is that our TPAs negotiate the pricing, and we don't even know what they've negotiated for. So I'm trying to get some transparency around that issue. I don't know how to do it without direct contracting with the providers. And it's something that I'd like to throw into the mix for further discussion.
You will note that as a discussion point as we go. Okay.
Okay.
I'm going to note it right here. Okay, thank you. Moving on. And another nice long list of considerations for the next medical TPA RFP. We want to be able to receive rebates on drugs through the medical plans. So you may recall a lot of medications are provided in different sites of care, and GHIP is not receiving rebates on those today. So we want to explore that possibility. Checking into air ambulance coverage, which is notoriously surprisingly expensive and can kind of, we end up with some shocks to participants. So just digging into that and making sure we have those in network and pricing is fair. How to handle a deductible if the member changes groups mid-plan year can be a little tricky sometimes, so making sure they have that capability. We're going to ask for options for additional support on members who may be experiencing cancer on their cancer journey. The ability to carve out GHIP from book of business when implementing some mandated changes that provides the GHIP with some flexibility to align with some effective dates mid-year. Very often these things are done calendar year. The ability to share archived data with new SBO vendors. So, for example, if ultimately there is a new health data warehouse vendor procured and implemented, we just want to make sure that the carriers are willing and able to share the data, because if the archive data, the older data, because if not, then that'll be a little bit tricky to make that data warehouse valuable. The ability to support mental health parity testing for both non-quantitative limits and quantitative limits. The ability to send data to Lantern, which is the state's Center of Excellence surgical vendor. Make sure that they can coordinate so that we can optimize that site of care. The ability to automatically reverse claims. The ability to comply with relevant state legislations as they evolve, the ability to send lab data to the data warehouse. This one will be pretty impactful too. Just how are they defining engagement in their care management programs? You know, a lot of what you will hear about in a procurement like this is the ability of that carrier to really support people with complex health problems and make sure that they are having good health outcomes. And so what does that really look like and what does it really mean? So we'll be digging into that topic as well. Other questions? See a hand up, please let me know.
I was just gonna ask, and this might, sorry, Colleen Davis. Just on the item, and you may get into this, but on retroactive reversal of claims for retroactive termination due to member ineligibility, do we have much of that occurring?
We defer to SBO. I'm not sure how that ended up making the priority list. Has that been a headache of recent years?
I would say let us take that back and look into it. I don't think it's a large issue, but something that of course we just want to be able to address preemptively, but can definitely take that back and provide a follow-up at the next meeting.
Thank you.
So Director Maxwell here, I guess, has it been 5 years since we went out to procure TPA services?
Yes, that is correct.
So I guess I would just like for WTW to kind of share with us what changes has happened in this marketplace when you look at governments across the country as to what new things that people are looking for in a procurement of this nature. Is there anything that's changed? Because obviously healthcare changes from year to year. And so I would just be curious from your standpoint, is there something we should be looking at? I know there are things that we've done as far as directing people to get certain services done in a particular standalone facility as opposed to in the medical facility, which I have follow-up questions on that. But can you maybe elaborate on that a little bit?
What's changed in 5 years generally?
Yes, and obviously nothing's changed really with us because we've been
Yeah.
under the same contract, but I guess what's happened around us? Like, for example, have there been carve-outs of GLP-1s in other states to kind of figure out, just to separate that from other prescription drug plans?
We have a lot of content on GLP-1s a little later, so I may just hold that one for now. But yeah, for sure, some states are choosing to discontinue that drug for weight loss only. You know, they'll provide it for a diabetes indicator. Some states are, Connecticut made an applied to try to manufacture their own generic for Connecticut residents. There is talk of direct contracting for sure, just a lot of interest across the board because people just can't figure it. There's a lot of concern in the market about the high prices of these drugs, and then you're seeing direct to consumer at a much lower price point. You're seeing some direct contracting at a much lower price point, and then that leaves a question for us who are leveraging our PBMs. You know, why are we paying maybe 3 times as much sometimes? So that it month to month, that is really changing. And so you'll get a lot of information from Brian Holleran a little bit later today. Beyond GLP-1s, which has been the headline in health benefits management for the last few years. I think a newer strategy that I have seen states do in particular is that reference-based pricing with hospitals, where, so Washington, I think, did this pretty, kind of the latest one. And they're saying, if you want to be the carrier for our state employees and our retirees, then you're only going to pay out to these hospitals at 2 times Medicare or 3 times Medicare. And then they make some adjustments to that old statement to like protect rural hospitals or protect hospitals that are serving lower income areas. I think 5 other states have done that with mixed success. Some have saying they're saved money. Some are saying they've driven hospitals out of the state. So kind of the consulting view on that is be very, very careful. Also, when I have mentioned that to SBO, like as we're preparing these kinds of meetings, it just doesn't feel like it may be possible here just due to how much leverage the hospital and the big medical provider systems leverage in this market. And you have a few, and they really seem to own everything. I think a larger state with more dispersed, smaller providers can kind of leverage their buying power for them a little bit better. So it is an idea we should keep in mind, but not recommending it short term. So that's a state specific thing. I think the other, what's happened in the last 5 years can be more generalized to all different kinds of employers, and there's new transparency data available as a result of federal legislation. Carriers are trying to leverage that data to get price competitive with each other, as well as try to help their clients, their members find the best doctor at the best price, best quality, best price type of care. So that's new and still evolving, and we should be talking to them about how they're using it and how they're going to bring it to the benefit of GHIP. So definitely transparency data is kind of new, and care management programs continue to be more prevalent, more popular, and with bigger claims of improving outcomes and optimizing savings. And so I think we want to also be testing just what's new and what that we're not leveraging today, what might be a little bit different, and to what extent can they demonstrate the efficacy of the program. Digging into that a little bit more.
Just a follow-up question, Director Maxwell here. Obviously there is a scarcity of primary care physicians, so it's hard to get one, right? Or one that's accepting new patients, or the model is a concierge service where that's enough for somebody just to say, I don't want to pay an additional $100 a month to somebody just to guarantee that they'll see me when I need them. So how does that go into this type of arrangement? Is there something we should be considering given the dynamics within Delaware?
So you can't just, plant primary care physicians and harvest them next year. So, it'd be a matter of talking to your carrier partners about whether and how they're trying to attract more primary care providers to the state or to the region, but also are there other alternatives we could deploy, beyond just going to a regular doctor's office like telemed. There's a lot of virtual vectors that care. Not all care, but a lot of care can be delivered virtually, and that just does tend to open up access for members. So we would also be exploring those programs during this RFP.
Bill Overley? Yeah, just to follow up on Director Maxwell's comments, and excuse me, somebody in here must own a dog because I'm having a little bit on allergies, but regardless, the disparity between freestanding facilities, the cost disparity is significant in Delaware. Willis Towers Watson has generated that information for us. At the subcommittee level, over the last couple of years, maybe going back 3 years, we tinkered with steerage, what we call steerage, adjusting the co-pays to try to get people to go to the lower cost facilities. It hasn't been effective. And I think that's a discussion that ought to be a bullet item on a future agenda on how we can look at steerage through education as well as perhaps increasing co-pays to the higher priced facilities. That's a discussion that I think this committee needs to have and vet thoroughly. Because the disparities are significant in labs and radiologicals. You'll see disparities of a magnitude greater at a hospital facility versus a freestanding facility for labs and radiological services. We stayed away from the emergency room because quite honestly, and I think the treasurer may have brought this point up, we discussed and we did increase the copay, I believe, to $100 if you go to an emergency room. Is that correct?
Let me, I can look at
I
that.
believe it's
Just a moment. I believe it depends on the plan, but
Well, regardless, we didn't want, if someone had a dire emergency, we didn't want to dissuade them from going to an emergency room. So we stayed away from that. But there is still room to tinker around radiological services and labs to drive people to a lower price provider.
And Bill, this is Director Harness. I do have an answer for the emergency room. So it does vary by the plan. If you're in the Highmark First State Basic or CDH Gold, it is just a 10% coinsurance after deductible. The Aetna HMO plan is a $200 copay for the ER. However, that is waived if the person is admitted. And that's the same for the comp PPO, $200, but it's waived if admitted.
Well, anyway, I think that there are significant savings out there, and it needs to be an agenda item for a future discussion around steerage. So,
This is Colleen Davis. I would agree, and I think that there's an opportunity for medical home real modeling for that type of thing, where you're getting more directive from your primary care physician or your primary care provider as to where you should go for the next level of care, wherever that might be.
We're gonna move on. Just generally, we want to, this project's going to identify medical TPAs that can support the strategic GHIP framework as it evolves. So you'll see kind of in the number of materials, we're still referencing the one that is currently in place, left over from 2025, as the new one has not been approved yet. But once it is, then we're going to be making sure that everybody can support that in the system. We're looking to provide competitive financial terms and performance guarantees, of course. We want to support GHIP's programs and plan offerings, including just administering the plans, integrating with other program vendors, as I mentioned, potentially supporting the introduction of an HSA qualified plan. And the core, just delivering is kind of the blocking and tackling, delivering on the core medical TPA functions, hosting that call center for the members to call into when they have questions, hosting the web portal for program management. Oh, you know what? I did have one more point, Director Maxwell, of like what's new in what should we digging into that's a little bit new, and just to the extent that SBO will and GHIP will rely on the carriers to do any kind of like targeted communications, right? So we want to get to people who are experiencing complex health situations, or high claimants, or just have a number of things going on. We can often identify folks, but it's just not great to, it's a little trickier to figure out how to get to them and get the right message to them at the right time. So that's just another whole area where we're going to be digging into what the TPA capabilities are around targeted messaging communications.
And we do have that in place currently.
Yep.
With both Highmark and Aetna.
Yep.
Bill, thank you, Bill Overley. Hope, the one that caught my eye in this was the increasing APMs, which I refer to as bundle care.
Okay, yep.
That they're both the same. Is there anything that would preclude us in this new RFP from mandating bundle care model? We're getting killed by in fee for service.
I would worry you would not get bidders, and we'd have a result like.
We have some experience with that, Bill, recently.
Yep,
No, I understand.
they just aren't, they don't want to do it.
Well,
The market is tough to move,
I
and
think it's pretty obvious why they don't want to do it,
well,
which goes back to my earlier comment about direct contracting and administrative only. So,
I believe we're, GHIP and SBR are have limited levers to pull to try and encourage continued provider adoption of APMs.
the
I think
history,
we have other tactics we could.
well, the history has been really awful. I mean, the last data I saw, again, was a very small percentage of the pie. Aetna was doing a little bit better than Highmark, as I recollect, but they're not making any strides in the right direction. And I don't think they will until we force the issue. I don't know how you force the issue, but I'd like to explore it.
You can mandate the members go to a high performing network, very narrow, that includes more APM. I am not saying WTW or anybody's recommending that.
No, I
Just
don't
that,
wanna put-
if you're thinking about what to mandate, you can mandate the members,
Yeah, I don't want
it's a little trickier to mandate the
I don't want to put
providers.
the burden on the membership.
Agreed, yeah.
I know where the burden ought to be.
All right, we have a couple members virtually that would like to comment. Karen Peterson?
Yes, thanks, Mr. Chairman. On the core medical TPA functions, the last column there, it talks about communications support. And I noticed on the draft scope of services, I don't know if we're going to discuss that separately or not, but it says on page 3, the second bullet says that they must support the state with communications to all eligible employees about medical insurance, the medical insurance program. We had the law change to include retirees also, because this is something that came up during the lawsuit where the state claimed they had no obligation to communicate with retirees about the medical insurance program. So wherever that language appears, that needs to be plugged into it, that it's employees and retirees.
Update, I think, in the next draft of that. Is there another?
Mr. Tashner?
Thank you, Director Maxwell. Jeff Tashner here. I just want to echo Bill Overly's comments on the alternative payment models. I've been around the FCBC for quite some time, and every time it comes up, we are given information that shows us that Delaware is seriously lagging behind other markets in terms of moving into those category 3 and 4, excuse me. And I know before I got back on my last stint, there was a time when we were actually shown, and it may have been an executive session, the GHIP medical spend broken down by third-party administrators. So by Aetna, by Highmark. I think they actually had the predecessor to surgery, to Lantern, Surgery Plus. And for those that provided Medicare and non-Medicare coverage, they separated it out and showed us the spend by third-party administrators. And I would think it would be incredibly helpful for the members on this SCBC, many who are new, to be shown that kind of information in the coming months so they can actually see what Bill and myself and others are referring to. We clearly are stuck in the quicksand of fee for service in Delaware. And while I understand what Hope said about, what can you do? You might not get vendors. If we don't do something to break out of the current model, then all we should be talking about is where are we going to come up with the money to pay the prices that other people are setting for us. And I would hope that we would be committed on actually trying to do something that would maintain quality while lowering the cost. And if the only option is reference-based pricing, and by the way, I know Vermont commissioned a study that was released in December through the Green Mountain Board. People can get it December of last year, that actually looked at their state plan and showed that by going to reference-based pricing, there would be savings in the hundreds of millions of dollars. Then I think that's what we got to do. Right now, we're allowing them, the providers, to dictate the market to us. And I think we're doing a real disservice to the people of Delaware, to the state of Delaware, to our members if we allow that to persist. So I just wanted to echo what Bill said and ask for somebody to show that data on GHIP spend by third-party administrators so that members on this committee understand exactly what the problem is that we keep talking about over and over again. Thank you.
Paul Bombach?
Thank you, Director Maxwell. I had a question, which was fielded a few days ago, but I wanted to put it on the record. In the left column where it mentions the musculoskeletal conditions, I asked what the inclusion rationale was, and I was informed that was based on this being the most costly category on a per member per year basis in recent years. So while it's not, I believe, a high occurrence condition, it's again a high expense per member per year for those who have that, which is why there's a focus on that. And I appreciate getting that answer to me and being able to share it today. Thank you.
Secretary Young.
Hi, everyone, and thank you, Director Maxwell, and sorry I can't be there in person today. I just want to echo the enthusiasm for steps we can take to drive our payers towards greater focus on alternative payment models and advancing down the continuum of value-based care. I think there's really exciting work going on in the state about participating in the multi-payer ahead model, which would be a big step to multi-payer alignment that would drive all of our providers towards greater upside and downside risk for total cost of care, and eager to continue those conversations and think about how we leverage those savings in this context, as well as in the Medicaid program and for all Delawareans who are paying too much for healthcare services.
Any other comments from committee members?
Pardon?
Do you want to just talk about next steps?
Yeah, I think that's really where we're at. We're still on time. Yeah, so the next steps are we the SBO and WTW will incorporate feedback from SEBC members on the scope of services, which again is we mentioned was provided as supplemental material, and incorporate that into the medical TPA RFP as it is developed, right? So we're still working on this questionnaire. Lots of opportunities to get some of these points in there. SEBC will review the medical TPA RFP at the March 23rd meeting and provide feedback on the full RFP document. So we do have a few months to work on this yet. And then we will incorporate that feedback into the final version, which will be presented for SEBC approval. SEBC will vote on the medical TPA RFP for approval at the April 20th, 2026 meeting. Questions on that?
Any last questions?
Lots more to come.
Thank you so much for that. And we'll be obviously
So I
working.
do see,
Oh, we got Commissioner Navarro. Floor is yours.
Yeah, Trinidad Navarro here. Sorry for not being able to be there in person, but I have to say that with the commercial market, we have shown how we can save with value-based healthcare, moving away from fee-for-service, the things that have already been discussed. And unfortunately, the SBO and Medicaid, they don't participate in that. It's just the commercial market. And there's a fee, there's a cost associated with that. And I think that's probably why the SBO doesn't participate. I'm not 100% certain, but I can tell you that if the SEBC would like, we could bring in our expert, resident expert, Christine Vogel, who can talk everything about the alternative payment models to reference-based pricing, and even the value of multi-payer. And she can explain all that better than I could. I could try, but I wouldn't want to give you, half of the actual scenarios that she completely understands. So if the SEBC would like, and if we could fit that into the next meeting, I'd be more than happy to volunteer her. I've already corresponded with her for the next meeting to give maybe a 15-minute presentation.
It's a pleasure of the committee. Commissioner Navarro has put forth suggestion that we have an expert come to the next SEBC meeting. As chair, I'd like to hear from committee members as to whether they would like that to happen at the next meeting or not. I see a thumbs up from somebody. Bill Everly, you have something?
Yeah, I've always found Christine to be extremely helpful and offer excellent advice. So I think it would be extremely beneficial for us as we move through this process to have Christine involved.
Okay, so what I would just ask of committee members, if nobody objects, which we have a couple of hands up, so let me pause my comments before I finish. So I think Karen had her hand up first, and then Yvonne, you'll be next.
Yes, Karen Peterson. I would certainly support that. I would find that very helpful. Thanks.
Yvonne?
Yvonne Gordon, I would find it helpful too, but just a question. Is WTW have any expertise in this area that we pay them to provide insight. Is this not one of the areas that they could provide some additional, in addition to her presenting?
We can review different types of APMs and talk about prevalence and, view on the effectiveness, but I think I'm really gonna vote, of course, but I think to have someone who is an expert in what is going on in this part of the market and the system in the state of Delaware I will be transparent. We don't have that level of expertise for your market, within WTW today. So I personally think she would be able to add additional insights.
That's fine, and I just wanted, consultant we already have. If you don't have the expertise, absolutely, but it could
Also,
be.
Yvonne, I know you're trying to save some money, but this won't cost us anything, so I think we'll be all right.
No, I'm not trying to save it, but we already pay them, and I would think they would have some expertise in this area to complement her presentation, but apparently not. So I'm fine. My hand's up to vote for it. Thank you.
Commissioner?
I'll just close with, a few years ago, the General Assembly passed a bill that created the Office of Value-Based Healthcare Delivery. And with the premise of preserving primary care, the premise of lowering costs, the premise of keeping providers here in Delaware and not moving to concierge service, and among many other things. And I think we've achieved that on the commercial market. That's the ACA essentially. But we've fallen short because we weren't able to include the SBO and Medicare and the bigger players in Delaware. So we are. They mentioned Christine Vogel. She is the resident expert. No disrespect to Willis Towers Watson, but they are correct. They don't have the expertise on a more granular level that Christine has, and I think that the board would I'm almost sad that I hadn't offered it sooner, but I think the board would benefit from hearing from her expertise.
Any other comments before I conclude the conversation? Seeing none. Okay, so what I would ask of committee members as to work with the SBO to develop an agenda of topics we would like to hear from Christine. Obviously, she can give us an overview, but things that we think pertain to us directly, as I'm curious as to what the cost would be for us to actually participate in this and the like. So I think that would be one item that I would say, but if we could work on getting agenda items of things we want them to address when they come to speak to us, I think that'd be extremely helpful. Bill Overly.
If I might, and Bill Overly, I'm sorry. And Christine may have access to this training. I'm not certain. I know Willis Towers Watson does in terms of the cost disparities between freestanding facilities and hospital facilities. I think that needs to be injected into the discussion as we look at it holistically.
Yeah, it could be as high as tenfold.
I know.
Yeah. And I don't think I think most folks on the committee already know that. And that's why we, try to send folks to centers of excellence in other places. But the cost is significant. The savings is significant. It's just a matter of figuring out how to do it. And I think we'll be able to provide some suggestions. And to Director Maxwell's point, there's a reason why. I mean, it does come with a cost, and it's whether we want to spend money in advance to save money later. That's one of the things that we'll have to discuss as a committee.
I'd like to move forward with the agenda item number 5, which are the financials. So I think, Brian, if you could walk us through the financials, please.
Thank you, Director Maxwell. Brian Stitzel from WTW. Real quick on the financial section, we have in here both the the fund report financials for the month of October, as well as the quarterly financial reporting provided by the carriers. As with previous quarters, while there is a separate deck summarizing the quarterly financials, we've included a high-level executive summary with the highlights of that quarterly financial reporting. We don't go into that in detail simply because there are differences between that and the fund reporting relative to timing, bucketing, how the different budget components of the quarterly financial reporting are provided. But certainly, please let me know if there are any specific questions relative to the carrier quarterly financial reporting, and we can address those either directly here or with follow-up on any questions that we can't answer here. Specific to the October financial fund report results, my apologies, I see a typo here. As I get to the slide, it says September in the upper left-hand corner, which should certainly be October. As you can see, in total, October results were a little more than $13 million better than budget. Specific to the individual components, premium contributions were about $300,000 worse than budget for the month, primarily due to two key factors. One being simply that you can see the pensioner share of premium contributions for the month of October were not processed in the fund. So that creates a $1.1 million shortfall relative to budget, expected to come in November. So you can see the forecasted November amount here of $2.3 million, with that amount expected to be trued up in the month of November. And then over here, relative to non-payroll groups, there was a double payment received from the city of Dover, which includes retroactive to September. So again, you can see that September actuals were a little bit lower, made up in October. So that accounts for the noise in the actual October premium contribution revenue relative to budget. From an other revenues standpoint, you can see a big difference between actual and expected, being $7.7 million better. That was also a timing issue. We had expected a budgeted $7.3 million payment for the manufacturer discount program, which is part of the EGWIP, which is done on a quarterly basis. That amount was expected to be received and processed in September and wasn't actually processed until October. But to the positive, the actual amount was about $500,000 higher than expected. So again, you can see we expected this $7.3 million back in September. We did not get the actuals until October, with all other revenue components coming in reasonably in line with budget. Claims were also better than expected, approximately $5.7 million. This has been an emerging trend, mostly driven by, I hate to use the word favorable GLP-1 experience, but favorable relative to budget. Recall, as we've seen over the last few months, when CVS made the formulary change beginning July 1st, or the beginning, excuse me, of FY26, to remove Zepbound from the formulary in favor of Wegovy, we saw a dip in utilization beginning in July, and that comparable dip has continued for August, September, and October. So you can see again, back here in July, we were expecting this roughly 5,900 claimants with about $7.8 million in spend in July. And you can see there was actually a big dip in July. And then we've sort of trended at that expected month-over-month run rate, with August 9% higher, September 6, October 6 against a budget of 887. So the run rate has continued at the level, but we haven't seen this bump back up of, call it, prior Zepbound scripts flipping over to Wegovy. So in total, we're now expecting a lower full FY26 actual spend for GLP-1s for weight loss compared to what we said in the budget. I see a bunch of hands raised. Commissioner Navarro, you're number one, so I'll turn the floor over to you.
Hi, Trinidad Navarro here. Brian, you're number one, buddy. Just a quick question. Was it dip because that folks are no longer taking the drug? Or is the dip because the savings from Zepbound to Wegovy? Because I'm concerned, and I've always been concerned that when this happened, that some folks may just discontinue and could potentially have, other negative impacts with their health.
Yeah, so the dip appears to be solely due to people discontinuing utilization, or at least discontinuing utilization of Wegovy covered under the plan. Doesn't necessarily mean that they haven't gone direct to Eli Lilly for Zepbound, paying for it cash out of pocket. That we can't necessarily answer. But clearly under the plan itself, they've discontinued use of the plan covered GLP-1, or said differently, they didn't switch to Wegovy, which would be the only data captured here.
So you think they're not taking it?
What
We don't
know
actually
for sure.
don't know.
Yeah, there's no way for us to track whether or not they have continued to utilize Zepbound because it might have been their preferred drug of choice and they're going direct to Lilly, leaning on manufacturer discount programs. That we can't answer because it's not captured in our data.
So
But
I'm sorry, I understand that. So did we see a bump in Wegovy?
We did see a bump in Wegovy. What we didn't see was a full parallel 1-to-1 bump in Wegovy.
Thank you,
And
Brian.
we thought maybe there might have been some noise at the beginning of the fiscal year, just in terms of, call it transition of care, or somebody might have had a 90-day supply of Zepbound and they were waiting for that to exhaust itself before switching to Wegovy. But again, you can see that the expected number of claims when we set the budget which was based on a run rate coming out of FY25, we were expecting there to be roughly 5,900 unique claims or claimants, which was based on a combination of Wegovy Zepbound utilization, and that number dipped all the way down to 4,300. And we didn't see a subsequent spike anywhere, at least not in the 4 months that we now have data relative to FY26. We didn't see a huge spike where an influx of people coming back to Wegovy out of Zepbound. We've just seen, as I said earlier, this normal expected just month over month increase in overall utilization. Now, I guess it's possible that the overall utilization increase has waned to a lower level, and some of this is people reverting from Zepbound to Wegovy, but certainly not at any level higher than what we were expecting to see month over month in increases in utilization at the time that we were setting budget.
Thank you, Brian.
Sure. Representative Bomback, I'm sorry. Senator Peterson, I think you're up next.
Yeah, yes, thanks, Brian. My concern is similar to Commissioner Navarro's. I spoke to at least one person who was on Zepbound and of course then couldn't take Zepbound and found out that it cost them $500 a month out of pocket. So my guess is that a lot of these people just stopped taking it because $500 a month is pretty pricey. My other concern is that we know from studies that when you stop taking GLP-1 drugs, you put all the weight back on. And so I'm kind of wondering how much money we wasted paying for Zepbound and then not paying for Zepbound. How does that square with what we've gained financially, by switching them over to Wegovy? Is that a big ticket item?
So the savings itself comparably Wegovy to Zepbound were material. That's why CVS made the formulary change, because they had negotiated a much better pricing deal net of rebates with Novo Nordisk than they did with Lilly. I'm not expert enough to talk to the efficacy issues or differences between Zepbound and Wegovy. Certainly your point is right, although I think some of the price points have come down, where at the time I do think the direct to Lilly cost was roughly, I think it might have been exactly $499 for 1 month supply, although I think that amount has come down. It's something maybe Brian Holleran can answer later when we talk about the GLP-1 utilization alternatives, things like that. Certainly you're right that for some people going direct on a cash basis is going to be cost prohibitive, which is probably why we saw the dip in terms of people not wanting to switch to Wegovy as the covered drug, but yet not being able to afford Zepbound on a direct cash basis. But the efficacy and clinical issues I certainly can't address. But from a pricing standpoint, certainly there was savings to the GHIP, even under the model that assumed that all of the Zepbound people would move over to Wegovy. There were significant savings to be had from the formulary change.
I'm just wondering, Brian, how much harm we might have done by pulling the rug out from under those folks who are now, according to studies, going to put all that weight back on. Was that just money thrown to the wind on our part?
This is Colleen
Treasurer
Davis.
Davis.
Can I just make a point real quick? This wasn't a decision that the SCBC made.
Right.
This was made by CVS, and we did not have an alternative. So I just want to be really clear about the fact that this was a formulary change that we did not control whatsoever. And so it wasn't a financial decision made by the SEBC. It was a decision made by CVS. And as our vendor of choice, we didn't have recourse here.
Yeah, I understand how the decision came to be as a result of the change in the formulary, but that, I mean, makes the point as to why we need to have control over the formulary, especially in cases like this, where a hugely popular and successful drug just gets dropped for profit alone. And we're left with people just out there hanging, either having to pay up $500 a month or put back on the weight that they lost. So I just want to put that out there. Thank you.
Paul Bombach.
Yeah, Brian, thank you. I've got two questions. First question is, we lost some members as of July 1, specifically University of Delaware and maybe 2 small municipalities. Is that reflected in the budget
It is.
projections?
It is.
Okay, so that 14% drop first, well, what was behind a 23% monthly gain expected in July?
Yeah,
Might be
so
something.
that good call out. Note that this slide is talking about the gross cost side of the equation prior to rebates. So that jump, that 23% jump, is partially driven by the run rate of utilization, but also driven by the fact that in the equation of the formulary change, Wegovy on a gross cost basis was much more expensive than Zepbound. The rebates were higher such that the net cost to the GHIP was less, and this is just focused on the gross side. So that's reflecting the higher gross cost of Wegovy compared to Zepbound.
Got it. Okay, second, and it's a quick question, is was the change to Wegovy made both for members who were using it for weight loss and for anti-diabetes? Because go ahead.
Wegovy and Zepbound are only for weight loss indications. The diabetic indications are different drugs, primarily Ozempic and Mounjaro, which had nothing to do with. So this doesn't affect the treatment of GLP-1 treatment for diabetes equation at all, because they're different drugs.
Thanks, Brian.
Sure.
Brian, Director Maxwell here. Two questions for you. One, you probably covered this on a previous report, but on slide 7, under other revenue, we were budgeting 180,000 in that far right other revenue column, but we actually saw a significant number in July and then above in September. Can you just touch on that real quick?
Yeah, you're right. We did cover it. We can certainly get you the exact specific items, but typically what flows through this other revenue are prior period settlements, performance guarantee payments, things like that. It's sort of a catch-all for things that are unanticipated but do happen from time to time. But we can get you the exact amount and what they're for.
Just one other point on page 13, which is the long-term projections.
Yep.
Can you just remind me again what determines the less minimum reserve? The reason why I ask is because if you were to look at the GHIP savings opportunity presentation, that minimum reserve is different in the out years than it is. The two charts aren't consistent.
Yeah.
So I just need to understand that because it skews what the surplus number is.
Yeah. So the minimum reserve is, call it or liken it to a margin to protect the fund from fluctuations in experience, claims or otherwise, but fluctuations in experience different from expected. It's a cushion built in to keep the fund cash solvent against adverse experience, and it's explicitly set as a % of expected costs. So, and you can see there's a big bump up from FY25 to FY26 because we introduced it for the first time in FY25 because of how FY24 experience ran so bad and the subsequent need for that 27% rate action. So it was a phased-in approach where we set FY26 at 2%, the minimum reserve factor at 2%, and we jumped it up to 4% for FY26 and later. And as projected experience varies, because in the savings opportunity slide, recall it's pulling GLP-1 coverage out of the equation, and therefore total expected cost goes down, and therefore similarly or parallelly 4% of that expected cost goes down. So the minimum reserve is set as a % of expected cost. So that's why you see variability there.
So I just think it would be just helpful, maybe we could just put it as 4% beginning, whatever year that is, where we're trying to get percent. That would just be helpful. That way, somebody doesn't think we're playing with the numbers to show a different picture. So I just want to make sure it's clear.
Sure. Understood.
Does anybody have any other questions on, I know you didn't touch on FY6 Q1. Is there anything, I mean, there's a lot of information in there, Brian, and I'm a numbers guy, but it's almost too much for me to comprehend. Is there anything you want to touch on in the quarterly?
Yeah, no, not really. Again, the quarterly reports are produced by the carriers. As I said earlier, the bucketing's a bit different. Historically, we leaned on that reporting to be able to look at experience by group or cohort, meaning actives, early retirees, and Medicare retirees independently. And as you know, for at least the last year, we've been able to bucket those groups our own through the fund experience. So we rely on the fund bucketing. There's the slide in the appendix relative to the results of those groups independently. So we rely more on this than we do the quarterly reporting anymore. Not unexpected and very similar to how results have tended to run over the last couple of years. Active employees have tended to run relatively close to budget, give or take, with early retirees running worse than budget simply because the older individuals tend to cost more. And then with the Medicare population generally running a bit ahead of budget because we set one rate action for the GHIB in total. But outside of that, no, nothing out of the quarterly reporting that I would want to touch on. And then back to the long-term projection real quick. This long-term projection again assumes that same smooth approach to uniform rate actions between FY26 through FY28 of 4.2%. With a singular rate action catch up in FY29. We've seen this 14.3% number come down now a bit because claims experience has been emerging favorable relative to budget and may continue to do so, predominantly because of what we just talked about in depth on the GLP-1 side. At the end of Q2, when we have a good solid 2 quarters worth of data under our belts, we may ultimately refine the out year projections of claims experience as well, which hopefully should have a positive outlook relative to where we're looking at things going from an FY29 standpoint. Couple of hands raised, Representative Bombeck.
Yeah, thank you. Can you go to slide 14? And I know you touched on this,
Sure.
but you know, the Medicare retirees clearly are carrying the fund, you know, paying for the lack of or the negative net income, if you will, from the other 2 groups. And as you mentioned, that's due to the unified rate decision that SCBC made. And I know we spoke about it, but it was at the time, and there was some dissent on doing the uniform approach. But you know, the result of that decision is we now have an enlargement of the imbalance and inequity across the 3 different groups. So hopefully SCBC in the future looks to reverse this trend and get towards a more equitable solution across the premium levels for the 3 groups.
So to that point, Paul, what do you suggest for the pre-65 retirees? Because obviously they're negative 31.2. Would you like to see their rates go up accordingly?
Do, but I think it should be done on a gradual approach, so there's not a one-time fix it, but have them pay through the nose, but rather have a 3 or 5 year glide path to get them closer to covering their costs with the state and the retiree portions covering the costs closer to that 100% level, and then a reduction of the premium from the state and from the Medicare retirees so that they stop overpaying by 25%. So I think we should be working towards equity across the 3 different groups, and a uniform rate decisions are the opposite direction of that.
Yeah, I would just remind you that on the Medicare retirees, the share of that is pretty much 95% state and 5% retirees. So this big windfall of savings that you see is going to come back to the state. So I just want to make sure that you're aware.
I'm assuming that as OMB director, you wouldn't mind that. But I think the important part is the group, I think, should be have rates that are more equitable across the 3 groups rather than such an imbalance.
Jeff Tashner.
So, Brian, stay on that same slide, and Director Maxwell, Brian, this may relate to your question. I'm assuming the premium contributions listed here, Brian, are the total. In other words, it's the state and the plan members. Is that correct?
That's right. It's the budget rates times head count.
Yeah. Is it possible that we could see this and break out the premium contributions between what the state pays and the plan members pay?
We have.
Is that in? Is it here somewhere?
So in the premium contribution slide, you can see active employees, what portion is, call it, funded by the state versus through payroll deductions. And then both on the Medicare side and the non-Medicare side for pensioners, what portion is state funded versus participant funded. Getting back to Director Maxwell's point, you can see the total for the Medicare is roughly $207 million, of which about only $10 million is actually paid for out of Medicare eligible pensioner contributions.
Great. I did not correlate the 2 tables. Thank you for doing that, because that's what as Brian was talking, I was thinking the same thing in terms of really to address the question Paul's looking at, we need to look at the state's share and the plan member share under each of the plans. And if I understood what Paul was asking was for us to come up with some sort of an equitable, not equal, but equitable approach in that respect. So I appreciate you pointing it out, Brian.
Sure. Representative Bombeck, I thought I saw your hand go up again.
I was looking at that and thinking that we have to be paying more for the pre-65 pensioners, but not on a per member basis, because the Medicare folks have Medicare paying for 80% of the costs. But this is on the whole plan, not on a per person basis, because I believe that we're paying a quite high level per member up for the pre-65. But again, across the entire group, the dollars are different than the on a per member basis.
Yeah, the per member shares are legislatively mandated and vary based on which of the 4 plan options the participant enrolls in.
Thank you.
Treasurer Davis.
Yeah, thank you, Colleen Davis. To, I think both Paul and Jeff's points, in 2020, there was a task force that looked at several opportunities to sort of shore up the imbalance. One of which was to allow retirees to go to the marketplace. And I'm not sure if Paul's suggesting that that's a solution, but I know Jeff was also on that task force and participated pretty closely with a lot of those 6 options that were proposed at the time. None of which I think were sought after, except for the one that did not require legislative intervention, which I think a lot of retirees were pretty upset about. But I wonder if there's appetite to revisit those suggested solutions.
Paul Bombeck.
Just in response, and thank you, Treasurer Davis. I know I was on a task force for making, what was it? Getting private pay, looking at various Medicare level choices, but I think you must be talking about a different task force. I'm not suggesting going out to the marketplace for anyone. What I'm suggesting is that the SDBC, which sets the premiums, and the legislature, which sets the ratios, makes more equitable decisions on the increases each year. And the unified one treats all 3 groups the same by definition as being unified, which doesn't make sense, given that one of the 3 groups is, I'll say, at a strong surplus that is carrying the other 2 groups. And I think that's very clearly a justification for reconsidering in the future those rate decisions across the 3 groups and moving away from a semi-automatic unified approach, which just amplifies the inequity.
Sharon Peterson.
Yes, thanks, Mr. Chairman. The other thing that kind of falls through the cracks when we talk about this is the fact that Medicare retirees pay a substantial premium every month that comes out of our Social Security checks. So these amounts shown here is not the extent of what we pay. We also pay premiums directly to Medicare. So I know this probably doesn't look like a lot of money, but if you added all those premiums in, it would be a huge amount. Thank you.
All right, we're running a little bit behind time. Unless there's any more comments, I'd like to move on to the next agenda item, which is the DHIP strategic framework.
All right. Good to go. Okay, thank you. So we have a hand up already, so.
I think Karen might have. Karen, did you get yours?
Yep. We introduced this topic, I think, recently and mentioned that we would be bringing a proposed strategic framework for SEBC to consider adopting for fiscal years 2026 through 2029. So this will be the first time we're showing this to you. I got out of control there, sorry about that. This slide doesn't have much new on it. It just reiterates the history of how the strategic framework that is in place today came to be. It reiterates the mission statement in place. We are not recommending a change to that at this time. I think an important box on this slide, though, is the purpose of the GHIP strategic framework and how it does direct SBO and provides guiding principles supporting how SBO evaluates GHIP's coverages and designs against innovations in the employer-sponsored healthcare space, measurement of our program goals against established benchmarks, and development of thoughtful RFPs and recommendations that encourage progress towards our priorities. So it really does drive a lot of decision-making on the SBO team. Couple recent and current dynamics affecting the GHIP. It's kind of three categories to think about, just general industry drivers. So these would be things that are really impacting everybody, small, large, employer groups, public sector, private sector, et cetera. So a lot of consolidation in the healthcare market, as well as labor shortages and supply chain disruption. They are ongoing, coming out of the pandemic still today, as well as the rise in GLP-1 utilization. Trend and cost management is just the theme, and kind of a headache for pretty much anyone sponsoring employee group benefit plans at this point. So that is pervasive. There are, the industry reacts to that by trying to come up with some innovations to help us, optimize care or save costs, including things like alternative plan designs, alternative payment models, value-based provider contracting. There are also all the time startups and disruptors or disruptive models that emerge into the health benefits space, and we always want to be evaluating those for fit and goodness for GHIP's goals and programs. So a lot of cost pressure, but also in response to that pressure, interest in kind of innovating and bringing some new ideas. Specific to Delaware, there has been a lot of ongoing consolidation within Delaware among providers and hospital systems buying up independent practices. We do have a new SEBC committee, as well as some new procedures, and so that does impact how we will manage GHIP going forward. Local legislation, including the passage of SB 120, focuses on strengthening the primary care system within the state of Delaware. And we do, again, similar to everyone else, there's pervasive state budget pressure due to changes in federal funding. And so the governor is requesting cost management strategies to reduce budgets across state departments and programs. A few things have changed within the GHIP over the years. GHIP has implemented Aetna One Advisor, which is a care management program and a navigation program offered through Aetna, expanded Lantern, formerly Surgery Plus, services, including offering Hinge Health, which is a virtual musculoskeletal health app for members, mandated that bariatric services be accessed via Lantern only, implemented Health Advocate for EAP support for members, and just generally updated and altered plan design to make sure that we're compliant with mental health parity regulations. I'm going to keep talking fast, so if someone sees a question, please let me know.
I have my hand up. Is it okay time?
Sure.
Can you go back to slide 3, please? So I'm not sure whether this would fit into mission statement or goals or strategy or tactics, but I would like to see the strategic framework to include mention of equitable premium rate settings across the 3 groups, and also minimization of sharp premium increases. I think that's consistent with what I'd like to hope that that's a view of the SEBC that belongs in here in one of those 4 categories. Again, equitable premium rate setting based across the 3 groups, and minimization of sharp premium increases. So put that in there. Thank you.
getting to the strategic framework, we are keeping a structure of 4 goals. I'll go through those high-level goals with you as well as the strategies. Goal 1, let's improve the health of GHIP members. Couple strategies along those lines, and we've introduced this topic already today: strengthen primary care engagement and promote preventive care. So we'll have a few different tactics to consider along those lines. We want folks to maintain a relationship with the primary care provider, get their annual physical exams, as well as their diagnostics and wellness requirements. As already acknowledged, a consideration along these lines is that there's a primary care physician shortage within the region. And so, that will provide some limitations to our ability to move the needle on some of these things. To measure this goal, we'll take a look at things like primary care physician utilization statistics, annual physical exam rates, and diagnostic rates, as well as percent of population attributed to primary care. A second strategy under this goal is engaging members across the health continuum to provide services and education specific to their needs. So start by identifying their needs by conducting a health risk assessment surveys, considering partnering with our TPA, medical TPA vendors. And again, we already discussed this in the medical TPA RFP discussion. Let's understand how they are helping us provide targeted communications today, as well as what the capabilities are that are evolving as technology continues to increase. So things like that. When we're talking about identifying high-risk folks and trying to target care and communication education to those households, we just need to remember that we always want to balance that kind of targeted outreach with privacy considerations for members. So that is something to keep in mind there. And we are generally relying on TPAs to be able to conduct targeted interventions. So, we would like to monitor the population risk score over time, the portion of the population with a healthy and low risk status. We also have available disease staging data, right? So we can see if people are progressing along disease stages or reversing, and things like that out of our health database warehouse and our carrier data. Identify unmet or inequitable healthcare needs of members. So this alludes to, the concept of social determinants of health. So depending on who people are, where they are, there may be geographic, economic, cultural, social barriers to accessing certain kinds of care. They may be living in care deserts. There may be cultural bias against seeking one kind of care or another. So there's a lot of public health activity and interest in understanding those dynamics among different populations within a community or a set of community, and then trying to help expand access to various services that may be lacking in those areas. So this is a fascinating area of healthcare management and great opportunities to just deliver care optimally to GHIP members in the state of Delaware. We can overlay housing and census tract data to approximate socioeconomic status and make decisions along those lines. A couple considerations to these approaches are that social determinants of health can be underreported. It may cost us maybe the cost, or at least an effort, to get some of this data built into the database. So we'll have to assess that over time. Again, back to that kind of privacy, that balance of privacy versus targeted communications. We don't want people to, feel like we're digging too much into their personal life or their economic status. Again, we rely on TPAs for that kind of targeted intervention once we do uncover opportunities to do some extra targeted support or communication. Fourth strategy here is to optimize vendor contracting to improve targeted member outreach. So I think we've already kind of touched on this in a number of different ways in the conversation today. Goal number 2 is ensuring members receive high quality and safe care that is cost effective and improves outcomes. So we want strategies that will increase the likelihood that our members end up at the best quality doctor for the best value, not always lowest price, and so that they have the best health outcomes after their procedure or their medical episode. So we have touched on this already today, right? Site of care, getting people to the ER, limiting their use of ER for non-emergent needs, embedding centers of excellence targets within our medical TPA RFP, implementing a modern provider search tool. I think this is an exciting opportunity for GHIP going forward. A lot of the member decision support or member navigation tool emphasis to date has been on choosing plan option at open enrollment time, or when you're choosing your plan when you come on to service initially. Due to federal level regulation about data transparency and all the data that's been dumped out on the internet by all the carriers for the last few years, there are a lot of emerging tools and approaches to take that data and provide high quality provider search tools to patients so that when they're looking for a doctor, they understand the high differential between different sites of care. They understand that this procedure or this diagnostic, you know, offered at a hospital versus a standalone could be potentially a lot more different. So they don't, not a lot of great ways to understand that it really existed in the past, but there's some emerging technologies coming forward. So to evaluate that. Sorry.
Bill Oberlin?
Yeah, said a lot more different. Are you talking about a lot more expensive?
It could be a cost, but there's also, the state of Delaware does already have a of limited scope at this point, but provider cost evaluation tool that's free to people in Delaware. I don't think it's being promoted right now. So, you know, there's some opportunities like that as well. We could promote what's there today, and we can also evaluate what we could build in, and yeah, so.
Yeah, I think there's an obligation, either through SBO or a partner with the TPA, to elevate that educational component so that people can, as consumers, can make good choices.
Great. Yeah, so I think it's an important component of the strategic framework. We have here our favorite topic, advanced alternative payment models, reward quality outcomes. So, you know, I think it starts with understanding opportunities to increase access to such models within the state, and then educating and working with providers and our carrier partners to expand access and expand the amount of spend that we have for models. Moving on to goal 3, managing healthcare costs for both GHIP as well as the members. An option that could be feeling a little bit new, again, is considering an HSA compliant plan option. This may be a great option for members who want to put a little bit less out of their paychecks and are willing to take on more risk, and may also welcome the opportunity to save long-term in a tax advantage account that they don't have today within any of the state options. So it is not just a cost shift, there's some other value to that. It's just a little bit of a different approach. We could consider differentiating plan options in terms of richness to, again, offer employees meaningful choice when they're choosing a plan, offering them the opportunity to pay less, take on more risk, or to pay more, to have more predictable spending across the year as they access healthcare services. As mentioned, some GHIP members may value an HSA compliant plan. But we also are recommending just exploring revising premium determination methodology, realigning actuarial values, and reviewing quarterly financial and key trends that would likely require the addition of SEBC work groups. I think what we're saying here is pretty complex and weighty topic, so would really require a lot of thoughtful, dedicated planning and consideration over a long term to think about those types of issues. To measure this, I think we take a look at year over year GHIP per member per year trend relative to market benchmarks. So there's a couple different ones. We can look at national ones. We can look at governmental employers. We can look at regional, put us to the geography, and just check how well we have done managing that trend year over year against the broader market. Managing, very impactful for managing healthcare costs broadly is managing pharmacy spend. It's growing. Pharmacy versus medical, it used to be about an 80-20 rule, that 80% of your spend is medical, about 20% is pharmacy. That's actually shifting. GLP-1s is one big reason for that, but there's others, including gene therapy, specialty drugs, biologics, things like that. They're just, the more that comes out of the pipeline, the more opportunities we have to deliver some great care. Just it can be very expensive. So exploring strategies to manage GLP-1 costs, cost reduction strategies such as in Senate Joint Resolution 7 and other such concepts like that. We're going to talk a lot about GLP-1s in a little bit, so we'll move on a little bit there. Identifying high cost conditions and implementing solutions. So we know diabetes behavioral health and musculoskeletal conditions can be very prevalent and also be high cost. And there are some options to provide the care along those lines at a more efficient and cost-effective level. So continuing to explore and invest in those types of solutions. We're always going to be pushing with our carriers to make sure we can obtain as much cost-saving innovations through our partnership with them, et cetera. So sometimes tactics along these lines may represent an upfront cost, something we need to think about deeply. ROI is a real, will we be able to measure it comfortably over time? So those are the types of discussion points to bring in when we're considering some of those tactics. Optimizing vendor management. Strategy 4 is optimizing vendor management and contracting. So we're doing this today in our RFP projects, just managing, optimizing discounts, optimizing pricing and procurement wherever we can, as well as fair and competitive terms for the state in our contracts and low administrative fees as much as possible. Yes, or sorry, Mr. Oberly.
Mr. Chair.
Okay, thank you.
I assume this is a question, I guess, of Stephanie and the co-chairs. I assume we'll have an opportunity to further discuss these issues when we focus on the PBM RFP.
Yeah, absolutely. This is just a very high level
Okay.
guideline for the focuses of the committee, which very much impact the day-to-day administrative work of the SBL.
No, I appreciate that. I know that it kind of got put on the back burner when we got the year extension, but it's something that I'm focused on. Continue the dialogue.
Final strategy along these lines is engaging members to use care appropriately and reduce preventable costs. So you can imagine some of the decision support tools around choosing their plans, around choosing their doctors and their sites of care, educating members on price variation, promoting alternative sites of care, et cetera. So we have had some focus on the decision support tool, plan option decision support tool offered by SBO to GHIP members, and haven't seen much movement or uptick in adoption lately. And that's not surprising considering the plan designs have actually not changed. And we see this very often where if you kind of are changing plan designs all the time and there's nothing really new, people just kind of default into what the tool told them to select a couple of years ago. We suspect that's what's going on. So, but we would put that kind of back under focus if there were a significant change, such as, for example, the offering of an HSA plan for the first time, right? That would be a really good time to be promoting that tool and make sure employees are really using it so they can consider that new alternative. Okay. And goal 4 is about accountability, transparency, and continuous improvement towards achieving these goals, right? So we will establish the performance measurement and reporting framework, which would include developing action items and key performance indicators, and benchmark aligned with the strategic goals, strengthening data analytics capabilities. That will be in partnership with the state's health data warehouse, of course. They are best positioned to help us understand what's possible there and help us make improvements. Use evaluation and feedback to refine the strategies and tactics, regular evaluations to assess progress, trying to assess member feedback and sentiment and evaluation and bring those findings into the framework over time. Strategy number 4, enhancing transparency through regular reporting, including developing dashboards aligned with the strategic goals, summarizing progress on the framework quarterly to the SCBC or a designated subcommittee or work group. Again, reporting in an annual report our results and communicating progress to the membership and the public. So that's a lot, and some of it very aspirational. There are some things specifically that there is intention to bring forth to SCBC for guidance, input, and comment over the next fiscal year or two. So, and some of these, are already in process, right? So it shouldn't be too new. For example, conducting a medical TPA RFP, evaluating alternative payment models, alternative plan designs, and network strategies. We're gonna do that in the context of the medical TPA RFP, evaluating Lantern, potentially expanding the role of Lantern, adding additional site of care steered strategies. The PBM RFP is for sure on this list. More to come on that. Potentially exploring an HSA compliant plan. Mentioning again, these care navigation tools and cost transparency vendors that may help membership arrive at that best quality doctor, best quality site of care for what they need. GLP-1 utilization management is going to be very dynamic over the next few years, with a lot of cost pressure and a lot of scrambling to make these drugs more affordable broadly. So we will need to be ready to pivot depending on what the market offers over the next few years. Bringing in social determinants of health and mitigating the impacts into our strategy, and potentially contracting directly with pharmaceutical manufacturers for certain medications. So to the right is just a little grid that helps you understand how each one of these aligns to the different goals that we outlined earlier. There's the same, more to come on all of those topics for sure the next year. Next.
Lieutenant Governor, you have your hand up.
Thank you, Director Maxwell. I just wanted to pull out a piece that I saw in your presentation and then add a quick comment as well. Kind of buried in one of the slides was recommendations to the General Assembly. And I think it's important for this group to remember that we serve the administration, we work within the administration, and we work in conjunction with the legislature. And just as SJR 7 asked us to take a look at certain things, I think it's very fair for us to have open and to promote open communication with the General Assembly about the work that can be undertaken there that complements the work that we want to do here, and that they have a very clear understanding of some of our goals. And to the extent that, you know, our SBO folks are liaising with our health committee leads or our JFC leads, and of course, I know that, Director, you're liaising with our JFC folks all the time, but it's often our health committee leaders who are looking at some of these issues. I know that our insurance commissioner does a lot of this work to make sure that he's educating the legislature about the pieces that fall within his mandate, but I think that we need to be clear with the legislature as well. The only other piece I would mention, just I really truly as food for thought, many of these things, many of what we see on the screen is really what we can do personally, from contracting, negotiation, infrastructure, plans. I also want us to remember that our state employees and retirees are human beings interacting with this incredibly complex system. And to the extent that we think that we need to understand what their experience truly is, and if some of these tools we're investing in really aren't moving the needle for them, I know that we've seen in the private market, a lot of employers have a lot of success in this area by really investing in the experience of the employee and helping them and giving them individual services to manage their healthcare journey. And so I really want us to think outside the box and not just be drawn into, oh, we can only work on contracts. I think we really also need to think about being employee and retiree centric in some of the work we do in order to support the employees and retirees that we serve. But thank you for this presentation and for giving us a lot of things to think about as we approach 2026.
Jeff Tashner.
Thank you, Director Maxwell. Jeff Tashner. One thing that struck me, and I had not realized this, our mission statement talks about affordable cost. But if you go to the general appendix, it defines affordable cost in terms of the annual healthcare cost trend that is lower than the national average for both GHR participants in the state. I was stunned when I saw that, because basically it's saying we're going to try to stay lower than the annual trend, but it doesn't talk at all about our overall affordability. And we have repeatedly been presented with evidence showing that the market in Delaware, in particular for medical, is significantly higher than comparable and surrounding markets. So I hope that as we're dealing with this strategic framework, we're able to change our definition of affordable cost to talk about overall affordability in the context of healthcare and not just staying under the annual trend. I mean, if we're 25% higher or 15% higher as a starting point, and we just stay below the trend or at the trend, we'll continue to be 25% or 15% higher. And I don't think that's adequate. I think we need to look at our overall affordability compared to comparable and surrounding markets. We've had a lot of data. And again, I was surprised when I saw the definition of affordable cost that was in the appendix and it being tied just to the annual trend. So I just wanted to call that out for other members of the committee.
I'll just close to say, there is many slides in the appendix, which we put together because we think they will support a conversation at some point over the next few months as this discussion continues. So you may see some of them in meat of a presentation at, SBO's direction over time. But if anyone has any questions on them, please feel free to reach out to WTW and we'll ask, or you can funnel them through SBO.
Yeah, please funnel through SBO and we'll be in contact with WTW.
Yeah, it's a lot of stuff.
That way, SBO is aware of incoming, it's a more efficient way to handle the business, so. Any other comments from committee members, or we can move on?
Okay. Okay, next topic is a VHIP savings opportunity around Lantern Surgeons of Excellence program and the incentive structure. So members may recall that recently Lantern provided a set of recommendations around tweaking some of the incentives offered to GHIP members when they utilize Lantern services. So we just had a little bit more information and some questions, answers to questions that were raised. So I'm going to speed ahead to the new content in the interest of time. And if people would like me to back up and slow down, I will take that feedback for sure. The incentive considerations boil down to these three categories. So Lantern is recommending for joint and spine category procedures, reducing the incentive from $4,000 to $3,000. The rationale for this is joint and spine procedures are actually really highly utilized in these types of bundled surgical COE models. People are pretty comfortable with them. They're very plannable. And people are just generally willing to consider using someone like Lantern for their knee replacement or something like that. So Lantern compared that $3,000 amount, which is the recommendation, to their book of business, and it would still be the second highest in their book of business. So greater than 84% of other Lantern clients that are providing incentives to members. The second one is cardiac or cardiology procedures. And here they're recommending an increase from $2,000 to $3,000. The reason is there's very utilization in this category, and the savings are potentially quite significant if a member chooses to use Lantern for cardiac surgery. So that's the reason for the increase. Relative to get a sense of how that aligns to others who are offering incentives, it would remain the second highest, incentive in the book of business for those surgeries. So still quite generous relative to levels being provided by other plan sponsors offering incentives to members. And then finally, gynecologic category, Lantern's recommendation is to reduce from $2,000 to $1,000 to better align with other procedures in what they call Tier C. And $1,000 remains, in the upper percentiles, about a third highest in the book of business and higher than about 54% of other Lantern clients. So moving on a little bit, we did have some questions from members in December, and here are the answers to some of those questions. So first one is, how did the unit cost of Lantern services compare to unit costs of traditional carriers, Aetna and Highmark? So they're was a savings analysis prepared in May of 2024. That is the best source of information for this question. So we refer members to review that analysis, and if another copy is required, please reach out to SBO and they can provide. Pardon me. What savings is Lantern providing to members, to GHIP members? So all cost sharing is waived when a member uses Lantern. So they're saving what they would have paid in cost sharing, which I threw in about 2% or 8% of costs based on the plan, actual values of the plan design. So they would be paying, if they went through the regular carrier, they would be paying a small cost share on their co-pays and deductibles. And Lantern, we waive all that. So they're saving that. And then they are also getting a cash incentive, which probably is greater than the cost sharing they would have saved. So they're really kind of, A, not paying anything out, and then B, they're getting this, the card that they can spend on other things. So that is the savings they're delivering to the members, and the savings delivered to the GHIP plan, so the payer, again, we're referring you back to that savings analysis. Confirm if travel was included in the 2004 savings analysis. No, the savings did not reflect travel costs that may have been covered by the plan. That said, probably those costs are quite minimal. There's a lot of care options where your people are within driving distance versus a very rural, say, Western state where they're literally having to fly to get the care necessarily, or drive and stay in a hotel for a few nights. So we just didn't see much in there, but I don't believe it was not included. And the Bill Overly is the question.
Bill Overly. Thank you, Mr. Chair. Bill Overly. The data that was shared with us on the cost analysis, that didn't include the travel costs.
No, it did not.
Okay, I was just trying to compare apples to apples. I don't know how significant it is, the savings, when you factor in the travel cost. I mean, is it possible to get that data to us?
This is Stephanie Harness. I can take that back. I will say the travel cost is typically very minimal, typically under $100 per member. We do receive that on invoices, though it's not something that we receive in our claims database at the current time, so it's not technically considered to be a claim, but I'm happy to follow up with you to see if we can get that information, although it wouldn't necessarily be tied to the exact claims and that savings analysis. But if you're looking for more of an average travel cost per utilizing member, we can definitely get that over to you.
Okay, I guess I can factor that into the information you've already provided us. Thank you.
The next question was around, are there equity concerns around reducing the incentive for gynecological services? And actually the new incentive, the recommended incentive of $1,000 aligns with procedures that are generally provided to males. Therefore, the incentives related to the procedures provided distinctly for males and females would be equitable. What proportion of total available procedures provided to members were delivered through Lantern? And just slightly under about 2% of available procedures were delivered through Lantern. Has Lantern demonstrated more favorable outcomes for GHIP members? This is a meaty question. SBO is continuing to investigate clinical outcomes for Lantern procedures compared to similar procedures provided under the standard medical benefit. So a detailed analysis will be forthcoming. Do have a few statistics that Lantern reported. Okay, so these are Lantern's numbers, not SBO/W2Ws, but so year to date, calendar year through September, members have engaged in 1,253 cases, including 763 completed procedures and 73 avoided procedures, which Lantern would, part of their value proposition is helping people understand if they really need a surgery, and then count that as a win if it's determined that actually that surgery wasn't necessary and it was avoided. Lantern calculates surgery care savings of about $26.05 per employee per month, of which about $4.57 is attributed to avoided procedures and avoided complications. These savings do not reflect the cost of member incentives. So it's a big complicated math question. To answer that more explicitly, I think what the asker wanted to hear, so we are continuing to work on analysis there. Final question, I think, was how does Lantern vet and credential providers? So they are They qualify by achieving some mandatory credentialing guidelines. And those who meet those qualifications are known as Lantern Surgeons of Excellence. You can click on that link to see what is publicly available to members and anybody who wants to see a little bit more information about how Lantern evaluates providers. Okay. So the next steps are for SEBC to consider the 4 revisions to those Lantern incentives for either a January 1, 2026 or July 1, 2026 effective date.
Questions from or comments from committee members? Paul?
Yeah, I'm disappointed that Lantern does not share the savings figures net of member incentives and the the lack of data on the number of cases for one of the categories we're being asked to consider a change on. It's kind of frustrating. I mean, do we not have the right to obtain that data? They're getting a lot from this program. I don't understand why the data's not forthcoming. Our meeting was 2 months ago. That not reflecting the cost of member incentives for something that we requested 2 months ago. Is this acceptable behavior by Lantern?
This is Director Hardis. I can clarify with the program lead who had done the outreach related to this for Lantern. We do absolutely have the member incentives, and I will say that information is included in the savings analysis, which was shared with members following the previous SEBC meeting. It does contain confidential and proprietary information, which is why it is not publicly shared. However, that is with members. However, again, that was a supplemental analysis that was done against the claims for Lantern. It was not done by Lantern, which in our opinion would make it a more accurate analysis, right? Because we are looking at the actual results as opposed to looking at meeting specific performance guarantees or goals. However, if it's specific to the numbers listed on page 9, I see no reason why we couldn't get that from Lantern, including the incentives. Again, though, that's there. I wouldn't compare it directly to the savings analysis, which was done from, again, an outside source being W2W, looking at the claims and comparing to the claims under Highmark and Aetna. But absolutely, if that is a request, we're happy to go back to them and get that information inclusive of the incentives.
On slide 6, there's 4 premium changes being suggested, but the table in the bottom only has 3 of them listed. I'm just a little underwhelmed with the data that's presented to us.
I will say, so the 4th one, which is cardiology, Lantern prepared the slide, so I'm opining on their thinking. There are 1 or 2 procedures a year. There may not have been a cardiology procedure in the experience period that they were creating that example table for below, and I think that's why they didn't include it down there. That is the only category where they're recommending an increase in incentive. The others are just decreases. And again, I believe the reason why they were including an increase is because when they have had utilization, the savings feel quite meaningful and significant and demonstrable in a way that, other categories, it's not quite that clear. So I believe that is why they were saying we feel very confident to increase there.
This is Director Hart. I can comment directly on that. Yes, we do not report out on any information. Typically, it's below 10 utilizers. It'll vary by vendor. You'll see that across the Division of Public Health and DHSS as well, just for the privacy of the individual. If we have less than a certain number of cases, we will not report on it publicly.
That's helpful. Thank you.
Director Maxwell here, just on slide 9, it talks about only 1.9% of available procedures were delivered through Lantern. So I would just like some response to, that seems extremely low to me as far as utilization of the Center of Excellence. And so what's attributed to that? Like, why is it so low? is it something we should be looking to our TPAs to kind of direct people to that? Because they're the ones that are really first being presented with a patient that would be kind of eligible to use a center of excellence. Help me understand the 1.9% compared to other states that have a similar arrangement.
Sure, I can speak to that a bit. Stephanie Hardis, Statewide Benefits Office. So the primary reason being this is a voluntary benefit. We do work with Lantern. They receive reporting from the Delaware Health Information Network, the DIN, and their claims through Highmark and Aetna, to where they can attempt to your point, pick up members, right? If I'm having claims submitted for joint surgery consultations and they're coming through the DIN, Lantern does get that data and can make those outreaches. Now, unfortunately, many providers do not report claims immediately. So what's happening is by the time they are getting to Lantern, procedures may have already occurred under the medical benefit, or the member may be so far along in their experience with their provider that they're unable or unwilling to switch to another provider. We have actually recently had discussions with Lantern on increasing the frequency of that reporting, but that would actually have to go more through the DIN and their capabilities, which is an outside resource, as opposed to something that unfortunately we do not send the claims directly, as we do not keep those in-house. But primarily to your response, it is a voluntary benefit. While we do offer very high incentives for members to try to move them over, if they're already very involved with their provider or it's part of their care plan, we're not always successful in getting them to move to another provider to do so, which again really plays into the high incentives that we have compared to other Lantern clients with no incentives. Where they see success is that their deductibles on the medical plan or their out-of-pocket costs are so high that offering a plan with zero copay or a 0% option is much more appealing. When we have such rich health plans to begin with, and it's not going to cost me anything as a member to get my joint procedure through Highmark, there's not always enough of an incentive or a pull to pull me over to the Lantern benefit, if that makes sense.
I mean, to me, it sounds like we're not incentivized, like we're incentivizing, but there's no way to get these people to do this unless we try to make it less voluntary.
Which, Director Maxwell, to your point, the SCBC does have the ability to do, have already done so with the bariatric procedures. They are not covered under medical. You have to go through Lantern. And the SCBC has considered previously carving out other procedures, such as joint, spine, other categories where we see high success under Lantern. But that, of course, is a plan design decision, which is fully up to the discretion of the SCBC.
Paul Baumbeck and then Treasurer Davis.
Is the supply of these surgeons of excellence high enough that if we made some of these procedures mandatory to go through Lantern to be covered, where our members would have perhaps longer waits in getting the procedures done? Could the supply of these and maybe even where in the state they're available be factors that affect that very low level of utilization by our members?
This is Stephanie Hardis that can respond to that. That's a great question. The Lantern provider network is very vast. So there are many providers in the area in all 3 counties, as well as Philadelphia, surrounding states, where we absolutely would have the capacity to accommodate that should there be an additional carve out for those procedures. As far as your other questions related to the wait times, we can get those exact numbers, but to my recollection, when we previously reviewed this with Lantern, they actually have expedited times in getting people into the office and getting them in with a provider sooner than what you would typically see under the standard medical benefit. But I'm happy to give those exact numbers for you, Mr. Baumbeck.
Thank you so much.
Treasurer Davis.
Yeah, Colleen Davis. And I think to the point that's being made on requiring utilization of Lantern as a benefit, it would be helpful to have that data that's forthcoming on outcomes, right?
Absolutely.
Because then it's a no-brainer, I
Took
think.
the words right out of my mouth.
Yeah, well, and I think you said it already, so
No, I
I'm
mean,
kind of repeating you.
that's a critical point.
Commissioner Navarro.
Just a quick question. I think on slide 7, it has like the 3 different types of categories, and the middle one's cardiac. And forgive me if you cover this and if this is a silly question, but if someone has to have a cardiac surgery, I don't understand what potentially you could have done for $2,000 to $3,000. And I don't mean to sound, I'm just ignorant. So I don't mean to sound overly ignorant, but if a person would require, valve replacement or open heart surgery or bypass surgery. I mean, I'm just thinking for like my own family experience. No disrespect to Lantern, but I would want myself or anyone, my loved one, to go to a specialist. So if I was required to go to Lantern, that's where I'm a little confused.
Thank you, Commissioner. This is Stephanie Harness. So those numbers, the 2,000 to 3,000, that is just the incentive for the member. It is not the cost of the procedure. Those
Okay.
procedures, of course, are much higher, can range up to $70,000 depending
Sure.
on the procedure. And of course, these are only non-emergent procedures. So to your point, valve replacement, pacemakers, defibrillation implants, those are the types of procedures that could be covered under Lantern, but certainly not all cardiac procedures.
Yeah, so that just shows my I wasn't paying attention. Thank you.
No worries.
Secretary Gordon. Jamie, all right. Moving on.
Apologize.
She's back.
I've gone through a whole dissertation. I apologize. Yvonne Gordon. Just on the point of education and our employees knowing that this benefit is available. We now do a statewide new employee orientation. So at this point, this is one of the areas too that we emphasize that employees, even current employees, kind of see it but don't pay attention to it. So we're at the point where we guarantee this, we talk about this, how beneficial this is. So we've done that with 800 new employees that have started since July. So part of that is knowledge, information, education.
Go on to the next presentation. Okay. So we are going to discuss another GHIP savings opportunity around the coverage of weight loss medications. And for this, we will have Brian Stitzel and Brian Holleran of WTW present this information. Gentlemen, are you?
Yep, I'm all set. Brian
right.
Holleran. Yep,
Hi, everybody.
all good.
Okay.
I'm Brian Holleran, pharmacy consultant with WTW. So I'm going to run through what other state employee health plans are doing with their weight loss coverage, what we're seeing in the marketplace, in the commercial marketplace for utilization management tactics to kind of curb spend, and also go through some federal updates on GLP-1s. So Hope, I think you can go to the next slide here. So a lot of this has been in flux, but currently it appears that, including Delaware, 14 states are covering for their state employee health plans, covering weight loss, including GLP-1s like Wegovy and Zepbound. As those costs have become unsustainable, though, we have seen a lot of change here. So in about the last year and a half, 5 states have discontinued coverage. So North Carolina, Idaho, Colorado, Ohio, and the latest is Michigan that will discontinue coverage on 1/1/26. Most of these states are not offering grandfathering. Grandfathering would be where current utilizers could continue to keep receiving them. The only state that we're aware of is Colorado, who did grandfather current utilizers, but their copays are going to be increased from $30 to $120 for a 30-day supply. Ohio did grandfather current utilizers, but just until their latest prior authorization expired. It's usually good for about a year, and then they would have to find another means of getting the GLP-1. I think we could go to the next slide. As far as those states that do cover, we're seeing them put a number of different management tactics in. So Alaska, Connecticut, Illinois, and Kentucky all mandate participation in a weight management program. So this could be through the PBM like CVS or through a third party like Virta. And some also mandate prescribing to a provider within that program. So kind of a limited prescribing network where members can only get a GLP-1 for weight loss if it is prescribed by a provider in that weight loss program. Connecticut, as mentioned earlier, is actually exploring manufacturing their own generic GLP-1 weight loss medications. Not sure where that'll go, but they are exploring that. New Jersey is implementing a weight management program also. What they're doing though, instead of not allowing coverage if you're not engaged and enrolled in that weight management program, they're just charging a higher cost share if you're not engaged. So $125 if you're not engaged in that weight management program compared to $45 for a 30-day supply if you are engaged. To our knowledge, they haven't selected a vendor yet, but they are exploring that. Kansas, they're updating their prior authorization criteria to a BMI threshold of 35, effective January 1st, 2026. So the standard here that Delaware also has in place would be a BMI of 30 or 27 with comorbidities. So just making it a little more stringent there. Lastly, Massachusetts is also going to require members to participate in a weight management program by VITA, and that is effective January 1st, 2026. And also VITA will be the sole prescriber of obesity GLP-1s. Again, members can only get them if prescribed by a VITA provider. Any questions there before we go to the next slide? Okay. Some federal updates on GLP-1s that I'm sure you've heard about in the media. So on November 6th, the White House announced that Novo and Lilly agreed to sell their GLP-1 obesity drugs at lower prices to Medicare and Medicaid, and also to lower their prices in the direct-to-consumer market. The impact of these changes on GLP-1s purchased by employer-sponsored health plans is not yet clear. There hasn't really been any direction there or mention of commercial plans. Also, although much is to be determined, it appears as though the coverage of weight loss under Medicare Part D will remain optional for states. We're expecting more guidance here, but right now it appears that it's still optional for states under Medicare Part D. Pricing will be dependent on the medication, the dose, and the channel by which it's obtained. So both Novo's oral form of Wegovy and Lilly's oral obesity medication will have a starting dose price of $149 per month. Both of these medications aren't approved by the FDA yet, but as part of that recent deal, they're being fast-tracked by the FDA. So we do expect them to be approved relatively soon, within the next couple months. The higher doses of those oral pills are expected to come at higher prices, though, than at $149 a month. For Wegovy, and we talked about a little about this earlier, but the current direct-to-consumer pricing is $349 per month for all strengths. But the plan is to lower that more to about $250 per month over the next 2 years. The Medicare price will be right in the ballpark there at about $245 per month. For Zepbound, the direct-to-consumer pricing is expected to be about $299 per month for the lowest dose, and up to about $449 for the highest dose, so around $50 less than we're seeing currently. But the plan is also to drop to around $250 per month over the next 2 years. Again, Medicare price right in the same ballpark at about $245 per month. And lastly, for plans that cover under Medicare Part D, the patient out-of-pocket costs are being capped at about at $50 per month, was the guidance. And here we just have, we wanted to show what we're seeing in the commercial space as far as GLP-1 management options. So it's a whole spectrum up top with pretty much the most common management option, which is just to cover GLP-1s for weight loss with the PBM criteria, which is really aligned with the FDA labeling, as I mentioned. So BMI of 30 or 27 with comorbidities, all the way down to the more innovative ways of managing, which is like direct contracting, leveraging direct to consumer pricing, since right now it is lower than in the commercial market. Also, some options that I mentioned with some other states are adjusting the plan design. So increasing copay just on these medications, putting in 30-day limits, lifetime maximums. We also see states, like I mentioned, raise the BMI threshold. So I've seen 35 or 40. Also to wrap around with clinical support, so to mandate engagement and enrollment in a weight management program from the PBM or from a third party, and then also always the option for exclusion. I think the message here, there's a lot of options out there, all come with different considerations. Some impact rebates, some don't, some involve some type of disruption, some are less disruptive, but just as costs rise and these costs become unsustainable, we're seeing a lot of plans get pretty creative with how they cover the medications. Any questions there before I hand over to Brian Stitzel to go through some of the financials?
Bill Overly. Yeah, as it relates to the Medicare population, assuming Delaware were to approve these GLP-1s for retirees under Medicare, have you done an analysis of what that additional cost might be to the GHIP, the state? Because I assume it's a significant population that may qualify. And in order to make an informed decision, I think we need to know what those costs are in today's environment.
We haven't yet. We did engage CVS on this, and they said that that's something that'll probably come about later. They're doing some underwriting on it now, but we have broached the subject, but don't have an analysis yet. But completely agree with you. Yeah.
Thank you.
Sure. All right, great. Hand it over to Brian. Appreciate it.
Thanks, Brian. Brian Stitzel from WTW. This slide exactly mirrors the slide we reviewed earlier in the fund report analysis, simply showing what we expect gross GLP-1 for weight loss expenditures to be for FY26 compared to what we had forecasted at the time we set budget. So the budget includes an expected spend of $137 million, whereas as of today, we're reforecasting that spend at just over $94 million. Specifically, again, appears to be likely due to the formulary change, removing Zepbound in favor of Wegovy. Level setting up at the top, back when the GHIP first elected to cover GLP-1s for weight loss, it was originally estimated, CVS had estimated spend in FY24 of $1.8 million. Actual FY24 came in at $14.2 million, ballooning in FY25 up to $53.3 million, and then again nearly expected doubling in FY26 at the $94.4 million. Flipping to the next slide, we have a summary of what the expected FY27, 28, and 29 savings would be if coverage for GLP-1s for weight loss were fully eliminated effective July 1st of 2026, or the beginning of the FY27 plan year with no grandfathering. You can see that under the coverage eliminated column there on the left-hand table in the middle, still has some spend even after coverage is eliminated. That's simply because we are conservatively estimating that there would be some continued utilization of the GLP-1s for other indications outside of just specifically weight loss, but relatively comparably low, modest utilization compared to if it were fully remained to be covered. Specifically, these savings are numbers estimated after rebates, so net spend from a GHIP plan spend standpoint. And then over on the table in the right hand side of the slide, we have a comparison of what potential fiscal year rate actions might look like if GLP-1s for weight loss were eliminated compared to the current expectations. Recall we have that 3-year smoothing of rate actions at 4.2% for FY26 through FY28, and then a single year rate action of in FY29, solving for the fund deficit after that minimum reserve that we talked about earlier of $0. And you can see comparably that the FY27 rate action could be fully mitigated down to 0% as opposed to the 4.2%. FY28 uniformly staying the same at 4.2%, and then FY29 impacted by about a comparable 2% reduction in required rate action from 14.3% down to 12.3%, solving for that same $0 deficit after minimum reserves at the end of FY29. None of these forecasts contemplate any changes in overall medical utilization, healthcare status, claims experience, comparably between the overall class of GHIP membership, both with and without weight loss. And then slide 9 simply provides that same comparable long-term projection under those scenarios, with the FY27 rate action being 0%, FY28 being the same 4.2%, and FY29 being at 12.3%. So I know I went through the financial implications and estimated savings relatively quickly. Let me pause there and see if anybody has any questions relative to the numbers. Commissioner Navarro?
How many folks currently does the state cover?
That's a good question. There's roughly, I want to say.
Commissioner, can you clarify your question? Say that again.
Sure. How many folks does GHIP cover for these Zepbound or Wegovy or just Wegovy now, whatever? How many folks are actually participating that the GHIP is paying for?
Are you talking about utilizing members of just GLP-1s?
Yes.
Go back 2 slides.
7, right? Slide 7.
Yep. So it's not quite apples to apples claims to unique members.
Yeah.
But generally they're the same, close enough. So in October, for example, there were roughly 5,300 utilizers of GLP-1s for weight loss out of the total GHIP non-Medicare population.
And if we chose to go a route like one of the other states had done to, for example, do like $120 a month for versus whatever they're paying now. I'm not real good at math, but how would that impact the cost to the GHIP?
So we could certainly separately do an analysis on the financial implications of leaving GLP-1 coverage in place, increasing the copays. I believe we've been told by CVS that the maximum copay that could be implemented without impact on rebates would be $200 for a 30-day supply and $400 for a 60-day or 90-day supply.
Now, Brian, just to clarify, that would not impact rebates based on those numbers that you just mentioned?
That's what we've been told by CVS, right? It would impact the overall calculation of CVS's minimum rebate guarantees because they would sort of reaggregate their expectations of the different buckets and the bucket specifically that GLP-1s would fall under. But the actual dollar amount of rebates paid by, in this specific example, Novo for Wegovy would not be impacted.
So just doing some quick math, if we just, and this is just a hypothetical number, it's actual number, but just if we went to $200 a month, sort of a co-payment, it would raise approximately $1 million a month or $12,720,000 a year.
The math isn't exactly dollar for dollar, because the co-pays that people are paying for anything, regardless of whether they're changed or not, but including GLP-1s or anything else, count towards the accumulators of out-of-pocket maximums. And if you raise the co-pays, then potentially some subset of this population is going to hit their out-of-pocket maximum faster, at which point their co-pay drops to zero because they've hit their out-of-pocket maximum. So it's not exactly one-to-one.
I understand, but for example, I think Colorado switched from $30 to $120. What I'm trying to illustrate or figure out is, I hope that we're just not looking to just completely eliminate GLP-1s for this, just to save the money, because we know it has had a material impact on folks' health over the last several years. And so if we were to change and do some of the things that Colorado or other states may have tried or are doing, how it would impact the overall dollar amount.
Yeah, so we can certainly take away that analysis model, a couple of things. CVS also indicated to us that they could administer the plan both ways, where the higher copay for the GLP-1s count towards their out-of-pocket maximum or are separate and singular, carved out, and would not count. Regardless of whether they otherwise hit their out-of-pocket maximum, they would still have that higher copay for the GLP-1s, and they could do it both ways.
And just slide 8, that's clearly it's spend after rebates, right? So that's the actual amount that it costs the state.
The GHIP, that's right.
Okay. Thank you.
Secretary Link Young.
Hi, folks. So we have been obviously thinking about the same issue in the context of Medicaid and talking to other states who have made changes. And it is a different population with more comorbidities. But what we have heard from many states is that they realized much less significant savings than they were expecting when they restricted coverage, because a very large number of people who they thought had only a diagnosis of obesity, once there was a change in coverage criteria, obtained a diabetes diagnosis that was sort of otherwise not sitting in their file, or had some other cardiovascular comorbidity that qualified them for use of a GLP-1. And so that has significantly reduced the actual savings that states have realized compared to what they were told to expect going into that. And so for our consideration on the Medicaid side, that's led us to be a lot more conservative in thinking about how much money might be on the table here. Can you talk about how you all are modeling that issue and how much switching you're sort of projecting in the context of the numbers on this slide?
Sure, that's the middle bullet there. So we've assumed that 15% of the otherwise covered utilization would find another indication or another way to continue to get coverage of the drug.
That's helpful. I will say, in our experience, again, it is a different population in Medicaid.
Yeah.
But we are seeing that states have had radically different experiences than they expected here on the Medicaid side, with many times greater than 15% of the population switching.
Anybody else have any comments? All right, I guess I will make a comment, is that I will say these costs are not sustainable. And I think I've heard from many members around this table that we need to do something to reduce costs. And, I get it, back in July 1 of 2023, officials initially budgeted $2 million for fiscal year 24 for the coverage of this, when in reality, it was $14 million, and that cost has continued to grow. So now we're talking about a much higher number, and we cannot keep up with it. And so I just want to make sure everybody's clear that on slide 8, when we talk about eliminating coverage, you could do away with a 4.2% rate increase, which would require a $31 million contribution from the state. In addition, you would actually have a reserve that's $10.8 million higher than if we continued along putting forth a 4.2% rate increase. And as you look out into fiscal year 29, it does show a decrease in the rate in the out year. So it's a compounding savings. So I get Commissioner Navarro's suggestion that he would not want to eliminate this coverage, but we definitely need to come up with a plan and make changes around this, because I can tell you that these costs are not sustainable. And as anybody could see, what other states are doing. California was on this list, that they've been removed from the top block, but you can see a number of these states, they can't continue. So I think it's fair for our participants to get advance warning if there's going to be a change to coverage. So I think we need to continue to evaluate what alternatives we can make with regards to coverage of this. Bill Overly.
I concur, and I think, well, I've been pretty clear on the GLP-1 problem from the start. If you consider that CVS gave the original cost estimate, annual cost estimate of 1.8 million per year, and that's what the SCBC based their decision on to include GLP-1s. But I guess going a step further, and I agree with just about everything you said, Mr. Chair. Is there a way to look or cost out what a weight management program might cost the state in lieu of GLP-1s? There's VERDA out there. I know other states have moved in that direction. And it seems to me to be a reasonable alternative for people who want to put the work in. Absent a serious health condition, obviously, I'm not ruling people out from having access to medication that is life-saving, but can we generate that information?
Sure, this is Stephanie Curtis. Absolutely, we have looked at that. I will say previously a restriction we had in place with our PBM CVS was when we had explored going to a weight management program, we're told at the time that would result in a loss in rebates because it's altering the utilization management criteria. Now, I will say that seems to have changed over the past few months. Namely, CVS has come out with their own weight management program that has been proposed to the SBO, and happy to share that information with the committee and the cost associated. We have very much been closely monitoring those other states who have implemented programs such as VERDA. I know that Connecticut has had a lot of really great success, and we've actually met with their benefits director a few times and have learned a bit about the program and cost. Now, of course, the cost that they are contributing to that program may change with Delaware, right? They have a lot more members in their health plan, which typically include lower administrative fees and lower rates. But we're happy to send over and work through that information to let you know what that would be. Most likely, if we were to enter into a weight management program not affiliated with our current PBM or one of our current TPAs, I will say an RFP would be required if we were to go outside of that, knowing that would likely exceed the threshold. But we could subcontract through our PBM, through our TPAs for weight management programs that they are in contract with, and are happy to explore that and get some options in front of the committee.
Great, thank you.
Paul Baumback.
Is there a sense, in a sense, a menu of cost-saving options for the SCBC to consider that could be presented to the members who currently use weight loss GLP-1s to get their feedback on which ones they hate the least, so that can inform us in making decisions? I'm assuming we've got some time to make this decision, and would we have time to poll the affected members to have that before we make our decision?
Or thank you, Paul. This is Stephanie. We typically would not, I'm assuming what you're looking for here is more of a survey to provide these members with options to get their understanding of what options they would prefer. We wouldn't typically target members of a specific drug directly. However, if the request is to develop a survey for employees, and of course can ask in that survey if they are a current utilizing member or not, we can definitely explore that option. I will say in the past, when we have done direct outreach for other programs, such as our diabetes prevention programs, of course, that weight loss and weight management is a very sensitive topic, and we have not always received the best response from members and employees in directly outreaching with questions pertaining to those conditions or to those programs. But we can absolutely explore a survey for employees. Again, that would be limited to employees, excluding participating groups and retirees, as we don't typically have their direct contact information. But that is something we can explore. Again, there may be some barriers in place that we'll need to look into a bit. I don't think it would be something that would occur in the next month or so. Again, there's a lot we would need to navigate in order to issue that type of survey to members. Just knowing, again, including medical information in a survey is very difficult to do and tends to have a lot of member hesitancy in reporting their own feedback. We do, of course, solicit public comments, which is an opportunity for members to provide that information, but a full survey may be, we may have some barriers, but let me look into that. And
I think my point is, I'll say framing, and if we say, would you like us to make no changes, or this which you'll hate, and this you'll hate, etc., then of course it'll be, we want no changes. But if the choices are amongst these 8 changes, which will cut the cost to the state, which are you least upset with? I mean, that feedback I think would be helpful.
So we can explore that.
Karen Peterson.
Yeah, thanks, Mr. Chairman. I think it's also important to explain to our folks that the cost has gone from 1.8 million to $94 million. I don't think people even realize that, for one thing. Secondly, does the state offer, do any of these plans offer gym membership? And if so, which ones?
Yes, thank you. This is Stephanie again. We do offer multiple free diabetes prevention programs that are paid for by the state, 100% free for members, to manage weight and to reduce risk of prediabetes and type 2 diabetes. Multiple programs are offered depending on which health plan you're enrolled in. So for example, if you're in the Highmark program, you have the option for Livongo, which is actually transitioning to Noom on January 1st, as well as the YMCA Diabetes Prevention Program and our additional Reciprocity Health Therapy Incentive Diabetes Prevention Program pilot that launched about 6 months ago. And if you're in the Aetna plan, you have the option also of the YMCA DPP, which comes with 4 free months of a family membership for the YMCA, as well as the entirety of the 12-month program being free of charge, including also the Solera Diabetes Prevention Program, which comes with other free enhancements like a free Fitbit, scales, other equipment. As well as the Hinge Health, I will say also is our musculoskeletal program, which comes with a physical therapist that the program participant works with for free, as well as a health coach. So we do offer multiple avenues for members to manage and reduce weight, 100% free of charge for the members, as well as we offer gym discounts as well, both through the health plans as well as outside of the health plans, which are available for all state of Delaware employees.
All right, thank you.
Treasurer Davis.
Yeah, my question / comment, Treasurer Davis here, is just really kind of focusing on the timeline. I think Paul brought it up. There are a number of options we can consider, but wanting to ensure that participants have a runway to make a knowledgeable decision, I think is extremely important. And if we don't make some type of movement, we're not going to end up giving them that time. So just want to kind of underscore the concern I have for a timeline.
Great, thank you for that. Secretary Lake Young.
Thank you for that. And I just want to sort of build on the timeline considerations. As I think, everyone knows, we are in a time of real change for the national picture for these drugs. As we noted, there are new drugs coming online. There are federal changes that are driving prices down. There is generic Ozempic on the horizon. And so, the cost picture for these drugs will look very different a couple of years from now than it does now. And so, I very much share Commissioner Navarro's interest in trying to make the minimum changes that we need to make now in order to get us through this period to a timeline where the cost picture for these medications looks different, because they are, as everyone has noted, they are life-saving drugs that are treating a condition that we previously had no effective way to treat. Biochemically, they are making people so much healthier, and they are making people's bodies just fundamentally different and fundamentally healthier in ways that are really, really important. And so, steps we can take to take responsible steps now, and get us through the next little bit, I think, are really critical.
Please disclose if you're receiving any payments from any of the weight loss drug providers at this time, please. All right. Any other comments? All right, we will move to public comment.
Mr. Chair.
Bill Overly.
Yeah.
You don't have to speak under public comment.
No, I thought we were going to go to other business.
What do you got in other business?
I just was wondering where we are with the PRC structures. I mean, are we going to have a discussion about that forthcoming?
Yes, so this is Stephanie Hardis. The PRC structure discussion will continue with the RFP development, as the PRCs and the structure of those evaluations are included in those RFPs. So absolutely, as we continue with the TPA, PBM, and upcoming the dental and consulting, those conversations will continue.
With the committee?
Absolutely, yes.
Okay, thank you.
Stephen LePage.
There's nobody signed up for public comment, so Steve LePage.
Mr. LePage, you should be able to unmute your microphone.
Yep, can you hear me?
Yes.
Okay. It has been stated that the state pays 95% of the cost for Medicare retirees. That figure is technically correct, only within a very narrow slice of spending, but it is misleading because it ignores the two largest parts of the cost structure. When a retiree moves to Medicare, the federal Medicare program pays about 80% of all medical expenses. The state does not fund that 80% at all. That represents a massive savings for the state, yet it is not included in the 95% figure. On top of that, Medicare retirees must pay their Medicare Part B premiums, about $203 per month, plus an additional rate state retiree medical premium for a total out-of-pocket cost of $234.80 per month. Active employees, by comparison, pay between $43 and $165 per month, depending on their plan. And this is where the difference becomes very clear. Retirees are paying between 42% and 437% more than active non-Medicare employees. Even when compared to the most expensive active plan, the PPO, retirees still pay over 40% more out of pocket. Compared to the First State Basic Plan, retirees pay more than 4 times as much. So when the state claims it pays 95%, it is only paying 95% of a small remaining amount left after Medicare has already paid the majority and after the retiree pays their required premiums. And this is the key point. When evaluating retiree health care, the state should be looking at the entire cost an individual already contributes, including the Medicare Part B and the federal Medicare share, not just a small portion that the state pays. Only when we look at the individual as a whole can we make a fair and honest comparison between retirees and active employees. The truth is simple. Medicare retirees are subsidizing the state both through their monthly premiums and through the federal Medicare funding their enrollment triggers. The state's actual cost burden is significantly lower than it would be for an active employee. If we're going to cite percentages, we owe it to the public to include all parts of the equation, not just the portion that affects the state's contribution to appear larger than it really is. Thank you.
Agree with these comments. All right, any other comments? Seeing none, I'll entertain a motion to adjourn.
So moved.
Got a motion, second?
Happy Thanksgiving.
So that's the second, okay. All those in favor say aye. Aye.
Aye.
Anyone opposed? All right, everybody have a happy Thanksgiving. Thank you.
Take care. I know, she's great.